in principle, when we suspect autoimmune problems in a patient, we treat two things. We believe the most important thing to treat is the hyperactive immune system, and therefore the most important treatment we can give are medications that calm down that hyperactive immune system. And for that purpose, we use, in principle, corticosteroids, so-called glucocorticoids. Those are oral medications, which are widely used in medicine, which are widely used in obstetrical care for certain medical problems. They are quite safe. They have some side effects, which increase with dosage and length of treatment. So we try to keep the dosages to a minimum and the treatment as short as possible. But generally, they are very safe and have been used for decades. And that is the principal drug we use for immunosuppression. In recent years, however, it has also become apparent that a big issue in autoimmunity is inflammation. And that means this is kind of a non-specific process where various areas in the body are affected by an inflammatory process. When we say inflammation, we usually first associate bacteria or viral as cause. But autoimmunity can also lead to inflammation. And because it has been in recent years recognized that inflammation is such an important component of autoimmunity, we have also started using anti-inflammatory agents to suppress general inflammatory processes. Now, we don't use the anti-inflammatories, the standard over-the-counter anti-inflammatories. We use drugs that also our rheumatology colleagues use for that purpose. Probably the best known one is a drug called Plaquenil. So some patients, not all, will get also Plaquenil or other anti-inflammatory drugs selectively. And the most severe cases where we either have failed with just glucosteroids and or Plaquenil, or where we see a lot of abnormalities, in those patients we will also resort in addition to intravenous therapy, usually with a medication called intravenous gamma globulin. Intravenous gamma globulin is once again a drug very widely used in medicine, in autoimmunity, in transplantation medicine. It is a blood product. It is made out of blood contributions, really plasma contribution, the immunoglobulins, the antibodies that we all have, combined from many patients. So it is a pool of antibodies against anything. And it is generally used in medicine when the hyperactive immune system has to be calmed down because it has antibodies against anything, calming down anything. And that we have found to be a very effective drug in selected cases. We don't use it in the majority of cases, but in selected cases we have found that it makes a difference. It's a controversial issue because it is very hard to do prospectively randomized studies on this subject, but in our experience we have found it to be effective in a good number of the most severe cases where everything else has failed. Now the problem, or one of the problems with intravenous gamma globulin is that it is quite expensive and that many insurance companies don't cover it, so it creates significant additional cost. For that reason, some of our colleagues use another product called intralipid. Now, intralipid is something completely different from IVIG. The only thing it has in common with IVIG is that it is also given by intravenous infusion. As the name said, it is a lipid solution, which is widely used in medicine as a nutritional supplement to people who cannot eat in standard ways. It was more or less accidentally discovered to have the same kind of immunosuppressive effects as IVIG, though I have to say that our experience with intralipid has not been as successful as with intravenous gamma globulin. So our preferred drug is clearly IVIG, but if a patient cannot afford the cost, then we will resort to intralipid. So all of these drugs have the principal purpose of suppressing hyperactive immune systems. Now, because there are some data to suggest that one of the problems from immune system activation may also be a hypercoagulable state, meaning a state where there is formation of little blood clots taking place within the woman's body. We are also, in conjunction with immunosuppression, trying to prevent clot formation. I personally am not really convinced that this makes much of a difference. I'm convinced that the important treatment is the immune suppression. But because there are some data to suggest that this may also be a contributing component, we usually give patients a baby aspirin a day, and not infrequently we'll also give them an anticoagulant by injection, but only at the prophylactic dosage. This can be either heparin or something that is called Lovenox, which has the advantage that you have to give it only once a day rather than twice a day as with heparin. So, two components, immunosuppression and anticoagulation. Both are usually given together.